Welcome back, everybody. the last leg of our conference today. Invite Dr. Dianna Bartsch and Dr. Paul Cammell from BPD Co. to come up on stage, and they'll present their snapshot on the research that they've been doing. Welcome to Dianna Bartsch and Paul Cammell.
Thank you all very much for having me, and I first just like to acknowledge the traditional owners of the lands that we're on today, the Wurundjeri people of the Kulin Nation, and pay our respects to elders past and present, and acknowledge the lands were never ceded. And I'd also like to thank the BPD Foundation for having myself along and Dianna along to talk about our work that we're very proud of, and all of the people at BPD Co. and in the networks that we've formed that have contributed to the work. We're very proud of it. I myself have been involved since the inception of BPD Co. For the past 6 years, and prior to that there were a lot of years of lobbying and campaigning where I learnt a lot from titans in this area that we're all passionate about, like Jan McMahon and Martha Kent, who aren't here today. And I was very honoured when I moved over to Melbourne in 2016 to remain involved with BPD Co. in the research arm and see it take shape. And I'd also like to acknowledge the incredible work of Dianna Bartsch, who's the coordinator of our research program, and all of the outcomes that we're proud to share today. So we had a good description of BPD Co. in that introduction, and really when the model of care was developed for BPD Co., we tried to learn from the centres of eminence and the models of care from around the world, and local experts such as Spectrum in Victoria and Project AIR and numerous others, to try and form a model of care that would really knit into the community in South Australia as a statewide model of care. And that's obviously a challenge. I've heard in the session I was just in and throughout the sessions today how real-world services, public health services and adjacent domains can deliver timely, individually tailored and respectful and often co-designed services to meet the needs of individuals, the very complex needs of individuals, without re-traumatising them, or creating a system which is often really has all the hallmarks of what we call an individual with borderline issues, which is it can be reactive or fragmented or unstable, which is often more of a reflection of the system that meets an individual in crisis rather than the individual themselves. So trying to model systems of care and support which are more receptive to the individual and collaborative is really important. Over in Victoria, I'm involved with the post-discharge services at Royal Melbourne, and really in that space, which is trans-diagnostic, and the HOPE program working with suicidality, and the Engage program working with crisis presentations, we're trying to think about specialised interventions that can meet the overrepresentation of individuals with borderline personality type issues or complex trauma type issues in that space. So I've learned a lot from the types of expertise, both clinically and in lived experience, that we have in the room today in terms of what general trans-diagnostic services like that can offer. And obviously there's a huge component of peer-led lived experience and carer experience that informs those services, and they're embedded in those services, and that's a big part of what BPD Co. offers as well. So if we look at the model of care, which is probably quite hard for you to make out on this screen, we really have got 3 phases, which are entry, starting to get help or intermediate level, and then more involved therapeutic services. And we can see that it's really a rich patchwork, and we can think about a model of care being like that and then trying to integrate that into a real world system, like a statewide public mental health system with adjacent services, as well as the complexity of having health networks within that state system that all want to do things a bit differently or do things on their own terms, and how we get and it can inspire these sectors to do work that's more specialised and appropriate, both at the clinical level and at the peer and carer levels. So some of our research is going to reflect this model of care and the stages of intervention that we've tried to put in place at BPD Co in South Australia, because we want to demonstrate what's already in the literature in some respects at a statewide level, how these different kinds of arms of a model of care can be effective. And the theme of today is reducing suicide and suicidality, and that's obviously a really important outcome, as is all sorts of other measures of well-being, symptom severity, senses of connectedness, and adverse outcomes, as well as for individuals engaging in the services, the acceptability of the services. So Dianna's going to come up and show some of the evidence that we've already got, and we're quite proud of the research program that we've developed. One of the things that's unique to South Australia compared to New South Wales and Victoria is that we have statewide record systems, and we've been able to proactively establish ethics approval and processes so that we can hopefully at a relatively large scale monitor how individuals experience and potentially benefit from the services within the model of care. So we're starting to. It takes a bit of time for evidence to emerge, but over this 6 years starting to demonstrate things that I'm sure a lot of us in the room would say we already know, but it's very, very helpful to be able to demonstrate these things to advocate further for this space. So Dianna's going to talk about our research. So thank you, Dianna.
Thanks, Paul, for that introduction. All right, I've got to make sure I get this right. Thank you all for sticking around. We're at 3:30 in the afternoon, so it's a hard time of day to keep listening, but I hope I can maintain your attention. So when I first started advocating for better services for people with borderline personality disorder in my own kind of team and area, over a decade ago, well before BPD Co was even a consideration, often I would be told, we don't actually have many people with BPD in our service. It's not our core business. And I found that really confusing and strange because I ran DBT programs, so I knew there were plenty of people in the service who had BPD. But when the administrators were pulling their reports from the systems, that's not what it was telling them. Why was this? The system wasn't capturing and reporting this diagnosis well. And when something's not coded, it's not counted. And when it's not counted, it can become invisible. And Bryn said something really earlier, which really sat with me, the vortex of invisibility. And this becomes a missed opportunity. It becomes a missed opportunity to advocate for resources, services, and support. So if we want to unite for change, we need to improve how we capture and report the data. Like obviously we've talked about lots of other things, but which are really important. But my focus today is I'll try to get you all on board with research and capturing the data. This ensures that people aren't dismissed, overlooked, or written out of the system. Because when people are visible in the data, they're visible in decisions, and that can save lives. So this was one of the first studies that we were involved in. We commissioned this from Flinders University. And they looked at recurrent mental health presentations in public hospital services. They had a very large data set. I think it was over 25,000 people who had a mental health ED presentation or inpatient stay across all of the public hospitals in South Australia, including regional. And then they looked at what happened between 2014 and 2019 in terms of people's representations. They found that patients with a primary diagnosis of BPD had a higher risk of representation than people with any other form of mental health condition. And I guess in this room that's probably not really surprising, but in South Australia at the time it was, because that wasn't, I guess, what had previously been reflected. We also found only 4% of people had a primary diagnosis of BPD attending the ED or inpatient settings, which I think is probably an underestimate compared to the research that we've seen from New South Wales, Victoria, and also internationally over the past couple of decades. And I guess it's really important to think about why that might be. They only looked at primary diagnosis. So there's a whole bunch of information that's missing there. And I think perhaps if we look today, a big focus of Paul and mine over the past 6 years has been about how do we improve the ways the systems capture the work we're doing and capture who needs the services the most. Another big aspect that we've all spoken about today is the importance of challenging stigma. We've had a few studies that have happened in this space. We had RIA, who looked at the attitudes of psychiatry trainees and how they differed between those in their first year of training to those in their final year. I think it was over about 5 years. She found that those in their final year had significantly more negative attitudes towards people with BPD. And I guess part of her hypothesis is they've had more exposure to the system, the health system, and potentially negative attitudes that they might be experiencing in those settings. So we've done further research, and in fact, a big part of what BPD Co has done since 2019 is we have a whole stream around training alongside research. So we've really focused on doing foundational training, which was pulled from the Project AIR model. They came and did a trainer with us back in 2019, and then we had our own program move on from there, and we had a student evaluate the first 600 or so staff members across not just mental health services, but also NGOs, drug and alcohol. We've also done further training with corrections, lots of areas. I couldn't even name them all. But what she found was that this one-day foundational training did have a significant impact on people's attitudes. People were more empathic, had greater treatment optimism. Kathy already spoke about this a little bit before, so check out the article if you want to know more. We're also looking at doing a follow-up in the next year or so and seeing, what's actually happened now since these people over the last 5 to 6 years have been out working in different systems and settings. Are their attitudes still positive? And is there any other things that we need to be doing on a broader system scale? There's also been plenty of talk today about having different levels and intensities of intervention. One of the things we do or have focused on in our stepped care model is really about increasing access to services for people with BPD and their families. Part of that is about how can we better respond to people in crisis who have BPD symptoms. I'll ignore that. To mitigate that revolving cycle that can happen, that data from Smith about the higher risk of representations between EDs and, what can we put between the EDs and the community teams to help mitigate that. So we also, once again, pulled from the Project AIR brief intervention model for people in crisis. We've called it Gold Card SA. If you're wondering what that term means, that's what we're referring to here. 4 sessions, 3 for the individual, 1 a week for an hour, post-crisis, ideally very timely to the crisis, and 1 for a carer or a support person of the person's choosing. We then embedded patient-reported outcome monitoring around these interventions, so people had assessments at their first session in the waiting room and then again at the end of their final session. And we also tracked people's hospital admissions, ED presentations 6 months before they had Gold Card and then 6 months again after their final session. And we were able to track over 300 people in those few years across both metro and regional areas. We found a 63% reduction in the incident of ED presentations in that post 6-month period. We found 65% reduced incidence of inpatient admissions and 82% reduced bed days during those admissions. In terms of patient-reported outcomes, we found a large reduction in borderline symptom severity and general distress, tapping in mainly to anxiety and depression. We also found moderate reductions in thwarted belongingness and perceived burdensomeness, which are proximal risk factors for suicide. People are more vulnerable when they feel like they're a burden to others or they don't belong. And that was just with a 4-session intervention. We've also looked at the ways in which we can increase access to other types of therapy. We're probably similar to every other state in Australia, very long wait lists for DBT, MBT, TFP, all the Ps. All the therapies, there's long wait lists for the specialist therapies. So part of this was about drawing on a common factors principles to be able to offer something people so they're not sitting on wait lists for so long. And then for some people that might be enough. They may just want that 10 to 12 week intervention and then come back for something later on, or other people may need to step into a more intensive therapy after that point. So at that point in time, in 2019, there wasn't a ready kind of model which we could easily integrate that fit our state's needs. So our team developed a 12-week program based on these common factors, pulling from evidence of what works across the different therapies. It was termed roadmaps, and we started a clinical trial to evaluate the group, a 12-week version. It's about 3 months for adults. We also have a youth version, which is for 16 to 18-year-olds. You get the occasional person outside those age ranges, but that was only 10 weeks to fit with a school term. In this initial study that we've published here, we were just looking at the acceptability and feasibility and I guess safety of this intervention. There was still, I guess, attitudes and clinical advice to not be offering short-term interventions, until a decade ago. So we wanted to make sure this was something that was appropriate. At this time, we found among the adult group, when we looked at the first 208 people who went through the adult and youth groups, about 38% attrition in the adult group, which is a little bit higher than what you'd like. I think the research shows in most therapies for people with personality disorder about 33%. And youth, we had 27%. However, we did start our clinical trial in 2020, which everyone knows what happened in 2020. So there was significant disruption to those groups due to the pandemic. Probably not as much as you got here in Melbourne, but certainly people not coming because they had a fever or they had a scratchy throat. We had a couple of Snapshot downs. Groups had to go online. At that point, no one was really quite used to doing groups online. So we had a bit of disruption that way. In stating that, we still had pretty good outcomes. We asked people at the end of the groups, did you find this useful? Was it helpful? Would you recommend it to others? Did you like it? Did it match your needs? And the ratings from post-group participants were above average on all of those aspects. We also looked at the incidence of ED presentations, comparing, once again, the 6 months before the start of the group and the 6 months after the group. And there was a 41% reduction in the incidence of ED presentations post-group. And in terms, I guess, overall safety, we were very fortunate we didn't have any loss of lives during those programs among the people who signed up. Since this paper, just a few months ago, you can check it out by scanning the QR code or just Google it. We published the results from the clinical trial of the adult version of the group. In this clinical trial, we took a quasi-experimental design, like when service opened up to specifically increase access to treatment, so it didn't sit well to do a randomised control trial in our setting at that point in time. But what we did want to understand was a short-term group intervention more effective than being on a wait list? So anyone who was on our wait list for more than a month, we asked them to do a second assessment just before the group started, and then we compared their progress or lack of progress on the measures during the wait list to that of those who were in the interventions. We had 41 people in the wait list and 80 in the intervention. And then as you can see from these graphs, our primary indicators, I guess, were borderline symptom severity and levels of personality functioning, considering self-function and interpersonal functioning. And you can see that as we mapped over the weeks, there was a differential difference or significant difference between those in the intervention who their symptoms severity significantly reduced relative to that of those in the wait list. And that was also across the secondary outcomes. We looked at difficulties in regulating emotions, so people increased their ability to regulate their emotions. We also looked at hypermentalising, reflective functioning, and that improved, and psychosocial functioning improved. We then followed these people up again at 6 months after the group, and these findings, once again, we found that people were still significantly better in terms of all these indicators of what we consider better for this study, were compared to baseline. So the findings was maintained. Another aspect of what we've been doing at BPD Co, and it was a big call, I guess, from the lived experience community when we opened, was about the need and the want for peer support groups. And at that time, we didn't have many models to draw from in the literature in terms of an effective group. So our lived experience project officer co-designed a group with a panel. It was a panel of people with lived experience and our service development manager at the time. They came up, they delivered a group program, a 10-week group program, and then we put an evaluation around it. So this paper that we published last year reports on the qualitative feedback from about 20 people who completed the group. They did about an hour-long interview with a researcher, and then we went through and themed the key aspects of what came out from those interviews. And that was, often people were reporting that from the group they felt a sense of growth and change. How did the peer group help? They felt increased sense of connection and feeling understood, and that's certainly something that's been talked about up the front here today. It's about the importance of feeling connected and feeling validated. And they also felt that the group gave them a sense of safety. So the group was facilitated by someone with lived experience. We had a co-facilitator who was a clinician, but they really took a very secondary role in their presence in the group. And I guess one of the key sub-themes that came out was people felt that in this setting, they had more of an equal footing. And the final study I'll talk about, we've done lots of studies, but these are the key ones I wanted to talk about today, was a project that Bryn referred to earlier today. We collaborated with Project DARE to evaluate a brief 4-session intervention for parents who had a child between 0 and 5 years. The group intervention was called Coming Up for Air, and it was based on the Project AIR manuals, which you can find on their website. We delivered it in South Australia, and we delivered them in child centres so that there was childcare on site to, I guess, reduce one of those barriers that obviously makes it very difficult to do anything when you have a baby. One of the key findings, that even with this brief intervention, parents reported a significant reduction in distress compared to the waitlist and improved mental health. And we've been doing some other work. We just finished another clinical trial, finishing up another clinical trial looking at a 10-week intervention, which draws on principles of mentalisation-based therapy and DBT, working with parents and their infants, and really sort of connecting to what Hayley was talking about earlier, about being able to, I guess, trying to intervene in that critical period between parent and child. So these studies and many others like them make sure that people with a diagnosis of BPD are seen and have the potential to inform policy and service development, strengthening our efforts to unite for change. But the most powerful data doesn't come from coding systems or outcome measures, but I'm still going to get it in there and make sure we think about it. It comes from people with lived experience. And that's why we have a lot of resources on our website. You've seen some out there today. Some are, you can scan the code to go to the BPD code website and access these. These have been developed by people with lived experience. We've got a new one, which is a fact sheet about, for first responders, like targeting how first responders, and I think we've got another one about emergency services responses. Yeah, I got it right, good. And we're doing a lot of work at the moment, or doing some work at the moment with paramedics, which we're really excited about for future. And while you're there, check out the research page. All right, thank you.
So this is a small token of appreciation for you.
Yeah.
Thank you, Paul. And this is for you, Dianna. Thank you very much.